We start the class today, sir?
Yeah, we'll go ahead.
Yes, sir. Thank you, sir.
Thank you. So the beginning of the new year seems to be lucky. We have all the students clearing their exam. So hope the trend continues and the practicals also become easy and you all clear it in the first shot without any difficulty. So my sincere congratulations and wishes to you for a successful clearing of your practical exams also. So I think all of you know what is the topic we are going to discuss today. Soundarya, are you aware of the class? What is the topic for the day? Are you there, Soundarya?
Please unmute yourself, Dr. Soundarya.
I think he's just logged in and not there. Rishavardhini, are you there?
Yes, sir, I'm here, sir.
Okay. You are aware of today's topic?
Yes, sir. Today's in comorbidities topic is obesity today, sir.
Okay, very good. So I'll just share my screen with you.
Yes, sir.
Is it visible?
Yes, sir.
Okay.
Visible, sir.
Okay. So supposing you get a case scenario like this, a 31-year-old female patient with a past medical history of class 3 obesity, the BMI of 46 kg per meter square, type 2 diabetes mellitus with a HbA1c of less than 5.7, well controlled on metformin, polycystic ovarian syndrome, non-alcoholic steatosis of the liver, and chronic worsening pain, both knees. He presents for total knee arthroplasty. The patient may look like this with the knees and why should she require a total knee arthroplasty? What is the reason for this? She is only 31 years old. But at this young age, why does she need a total knee arthroplasty? Again, this is going to be an interactive session, so please answer the questions. You can unmute and answer now and then.
Excess weight and
excess weight causing what problem?
Osteoarthritis.
Osteoarthritis of the knee. Very good. So the wear and tear is more because of the excess weight. And so if she undergoes an arthroplasty, then scar may look like this because of the obesity. It may not look very appealing or look cosmetically acceptable, but because of the obesity, it may look like this also. Okay, so whenever you have a patient like this, what is the definition of obesity, first of all? You should all know what is the definition of obesity. How do you define a patient as obese?
percent of excess body weight for the age, gender, and height,
Okay.
and also the BMI.
BMI.
High amount of adipose tissue compared with lean muscle.
Body
lean
mass.
body
Very
mass.
good. That is the correct definition. Obesity is abnormally high amount of adipose tissue compared to the lean muscle mass. I'll tell you later. There is another question related to this. So, normally, which should be more, muscle mass or fat?
Muscle mass. sir.
If in a healthy person, the muscle mass should be more than the fat mass. Okay. Whereas in obesity, there is an excessive adipose or fat compared to the lean muscle mass. Okay. So if the muscle mass becomes too low and fat becomes too high, what is that obesity called? Because of excess of
Sarcopenic obesity.
sarcopenic obesity.
Penic
Very
obesity.
good. The muscle becomes too weak. So how do you diagnose a patient is a sarcopenic obese patient? The answer is correct. Sarcopenic obesity is correct because the muscle mass is too low compared to the fat, and that's why you would have seen in some of the pictures where people weighing 300 kilograms, 400 kilograms, not able to get up and move and even attend to their own daily needs also, because the fat is so much and muscle mass is so less. They are unable to even do the regular movement. They will be all the time sitting, resulting in bed sores and other problems. They can't keep their hygiene itself. That will be the condition. So because the muscle mass is not there, what will happen to their hand grip and mobility? Their hand grip will be very poor. They can't even hold a glass of water.
What?
And their ability to get up and walk, all these things are very much affected. Okay. So that is the extreme degree of fattiness where muscle becomes so poor in mass and patient's mobility and day-to-day living itself is very much affected, and that is called sarcopenic obesity. Even though patient may appear too big, that their movement and their power is very, very limited. So that is the reason why obesity is defined as an abnormally high amount of adipose tissue in comparison to lean muscle mass. Okay, so you should not just simply say any person who has a little bit of extra fat, you should not say that he is obese. If he, I don't know how many of you watch the WWF program in the TV, where you find the fighters are all well-built fellows with huge body weight.
Yes.
But,
Yes, sir.
but their muscle mass is so good. Even though they appear huge and bulky, their muscle mass is much more than the fat. So body weight, BMI wise, they may be on the higher side, but their muscle mass is quite high. So they are not sarcopenic obese people. They are more muscular obese people. Yeah? So that is the definition. Abnormally high amount of adipose tissue. Then how do you quantify the obesity?
Based on body mass index.
Body mass index. Very good. So what are the various grades?
Underweight is less than 18.5.
Hmm.
Normal 18.5 to 24.9.
Very good.
Overweight is 25 to 29.9.
9.5. Okay. Very
Then
good.
obese class 1 is 30 to 34.9. Class 2
34 to
34.9. Class C is more than or equal to 40.
very good. So our patient already it has been given here as 46. So it is class 3 obesity, more
Yes.
than 40. Okay.
Yes.
So that is how you quantify. That is body mass. What is the other name for the body mass index?
Quetelet index.
It's also called Quetelet index. Why it is called Quetelet index?
Don't know, sir.
It is the name of a person, Alfredo Quetelet. Okay, he was the person who describe this body mass index. There is a small story how he got this formula. He was an insurance agent. Okay, so in those days, when you take insurance, if something happens to the life assured person, then the insurance company has to pay the entire amount. So if the person has paid only 1 or 2 premiums and he is insured for a huge amount, then the insurance company will go into a loss because he would have paid only say 25,000 rupees as premium, but he is insured for 10 lakhs. The company has to pay that entire 10 lakhs. So they wanted to find out who are all the people who are susceptible to die early because of this body weight and other things. Because in Western countries, obesity was very prevalent and people used to die very suddenly. So this man made a calculation based on the weight and height-based weight, and found out that these patients who are overweight or obese for their height, they all have a risk of cardiovascular disease and dying. So he described this to increase the premium. If the patient has the risk of cardiovascular disease and sudden death, they used to increase the premium. So actually it was for the insurance purpose. This index was found out by Alphonse Quetelet. Then there is another index called Broca's index. What is that Broca's index? Normally we use this Quetelet index or BMI only for calculating the various classes of obesity. But there is another index called Broca's index where you have to calculate the height centimeters, subtract 100 from that for men and 105 for women. This will be the ideal weight of a person. But 20% above this ideal weight is also considered as obesity. Okay, so all of you can easily make a calculation whether your body weight is according to Broca's index or not by measuring your height. Normally we measure in feet and inches. So how do you convert feet and inches into centimeter? Any idea? Supposing one of you is 5 feet 4 inches in height. What is your height in centimeters? 5 feet 1 foot is 12 inches, isn't it? So 5 into 12 is
30.48 centimeters.
2.5. 1 inch is equal to 2.5 centimeters. So first convert the feet and inches into centimeter by multiplying the feet with 12. So 5 into 12, 60. 60 plus 4, 64 centimeters is the height of a person who is 5 feet 4 inches. And then 64 multiplied by 2.5 will be 128 plus 32, 160 will be the height in centimeters. From that, if you detect 100 for male, it should be 60 kg. For a woman, it should be 55 kg. So a woman having a height of 5 feet 4 inches, ideal weight is 55 kg. And then if he is 20% more, that is more than 1/5. That means if he is above 60 kg, they can also be considered as obese. Okay, this is another way of quantifying the. Any other way, apart from these two commonly used calculations, BMI and Broca's index, is there any other way of quantifying the obesity, which are all called anthropometric measures? Any idea? So tricep skin fold. This is also another method of quantifying the obesity. Okay, so you can measure pinch this triceps, the back of the arm, and if it is more than 23 millimeters in male or more than 30 millimeters in female, that is also an indication of obesity. So this is how you do that measurement. There is a special calipers available to measure that. So you have to pinch the skin at the middle of the back of the arm and then use the calipers to measure the fold of skin which you can pinch. And if it is this value, then it is also considered as obesity. The next important thing is the waist circumference. So if the waist circumference at the which is called the waist. At what level you say it is waist?
At the level of umbilicus,
Umbilicus. What is the hip circumference? Where will you measure the hip circumference?
at the level of ASAS.
ASA, anterior superior spine. Very good. So if you measure your abdomen and if it is more than 88 in females at the umbilical level or 102 in men, then it is called, it's also included under obesity. Okay. And then you have to measure this waist to hip ratio also. So if it is more than 1 in male or more than 0.85 in female, that also indicates obesity. So this is how you have to measure. So you can measure the waist circumference here. Actually, the hip circumference should be measured here. But this picture shows a little bit lower measurement below the anterior superior spine, a little bit lower in the written hip also. So it's ideally it is measured, but the thigh fat is also included here. What is the purpose of measuring like this? Instead of measuring at this level, why are they measuring here? In these two pictures, if you see, this here the waist is very small. It maybe this is a normal person and this is the hip circumference. And here this is the waist and this is the hip. So if you measure this, what can you find out?
So central obesity and peripheral.
Very good. The type of obesity, whether it is android or gynecoid type of obesity, can be measured by slightly measuring at the lower level the hip ratio. Okay, instead of measuring at this level, if you measure it here, you will get the correct disposition, whether it is android or gynecoid type, central obesity or peripheral obesity. Okay. Now, what is the risk when the BMI increases? Why you are worried about the BMI and obesity?
It is associated with other comorbidities. Metabolic syndrome
Comorbidities. Very good. When BMI is more than 30, it's a strong positive predictor of ischemic heart disease, stroke, diabetes mellitus, and even sudden death. Okay, so all these risks are there if the BMI is more than 30. So that is the reason why you have to take care that you don't cross the point of 30. Now, what are the patterns of obesity? Already we have answered that it can be called as peripheral or gynecoid, central or android type, and it is classically described as apple versus pear shape. You can see this is female, it is more of a pear shape because the peripheral fat distribution is more, whereas men it is more in the central or abdominal part, and that is described as the apple type of obesity. So what is the classification based on the BMI? Already you have answered. In adults, it is less than 18.5 underweight. Normal is this. Overweight is this. Class 1, 30 above, below 35. Class 2, 35 to 40. And class 4, anything above 40. Now they have added super morbid to other super morbid obesity and all those things where people are more than 60 BMI also. Now, what is the role of basal metabolic rate in the pathophysiology of obesity? Now, we have to know the reasons why some people become obese, or what is the pathophysiology and the causation of obesity. So, what is the role of basal metabolic rate? How does this contribute to the person becoming obese? Is the BMR low or high in these patients?
Low BMR patient.
Low BMR. So more intake, less expenditure of calories results in weight gain. That is the most important reason for the environmental type of obesity. That is obesity hydrogenically created by our own habits. Okay, there are genetic causes where obesity may run in families, but majority of the obesity which we see here in the normal population is due to more energy intake and less energy expenditure. And resting energy expenditure is very low in these people compared to the exercise which happens in the normal people. In normal people, even when you walk for a few kilometers, you spend more energy. Whereas in obese people, the energy expenditure is low, so there is, even if you do little exercise, it is not spent as much as in the normal person. And exercise increases energy expenditure not only during exercise but also up to 18 hours after cessation of exercise. So that is the reason why one of the advice given for obese people when they are worried about their increase in weight, the first thing we advise is lifestyle modification. You eat less, spend more calories by at least walking half an hour to 45 minutes briskly, so that you sweat a little bit. That is the walking, not just chatting and walking in a very leisurely fashion. You should actually sweat when you walk for half an hour to 45 minutes, and your heart rate should be at least 80% of your predicted value. That is Broca's index. When you, we use during treadmill. What is the target heart rate? How do you calculate the target heart rate when you submit a person for treadmill testing? Bruce protocol, any idea? When you set up when you do a target treadmill testing to find out any occult ischemia in a patient, you subject the patient to treadmill testing. So in the treadmill testing, you first have to set the target heart rate, so that once the target heart rate is reached, you can stop the person from proceeding with the treadmill exercise. So that is calculated by 220 minus the age of the patient. That is the calculation for target heart rate. So supposing our patient is only 31 years, so the target heart rate we have to fix is somewhere around 189. 220 minus 31 will be 189. So we have to achieve up to 189 for a treadmill. But during normal exercise, when you walk, you have to walk in a brisk fashion to achieve at least 80% of your target heart rate. That means at least 140 should be your heart rate for a 30-year-old person. Then only you are doing the correct speed to spend the energy. On the contrary, if your heart rate remains at 90 and 100 and you are walking very leisurely, then the purpose is not achieved. You don't spend that much calories as you have to. Okay, so remember that when you advise any patient to go for a walk, you should tell them that they should achieve at least 80% of the target heart rate, which is normally set up for a treadmill test. When they walk, that much brisk or fast walking they should do. Then only the energy expenditure will be ideal. Otherwise, just saying that I walk for half an hour and you walk only 1 kilometer or 1.5 kilometers in half an hour, that is not at all going to be useful. Now, how to achieve weight loss? What are all the methods of achieving weight loss?
Exercise.
Exercise. First, reduction in intake, isn't it? First sentence here is more intake and less expenditure. So you must reduce the calorie intake that you are doing. So regular exercise increases the basal metabolic rate over time, and calorie restriction without exercise leads to only reduction in BMR to conserve energy, and the weight loss will be very slow. So both should be combined together. You must reduce calorie intake, and at the same time you should do exercise to increase the metabolic rate over time. So what happens to excess calories consumed? This is another way. How do you put on the fat in your body?
Excess fat is stored in the form of triglycerides, sir.
Very good. Where is it stored as triglycerides? Which cells?
Adipocytes.
Adipose cells.
Adipocytes.
Very good. Excess calories taken are stored as fat and triglycerides in adipocytes in the form of triglycerides. Very good. Now, what happens to adipocytes when fat gets stored in them? What is the change produced in the adipocytes when the excess calorie is stored as triglycerides in them? Will they become
It
bigger
will
in
increase
size?
in size.
Yes. So it increases in size, maximum size up to a BMI of 40 kg per square meter. Then if the body BMI goes beyond that, what happens is they start to divide and increase in number. Earlier concept was a person's adipocytes number is determined by genetic factors and it cannot increase. And that was the concept behind the procedure called liposuction, which is done for removing the excess abdominal and thigh fats in patients as a part of cosmetic surgical procedure. Liposuction. I hope all of you would have heard about this procedure, and some of you would have had a chance to witness this surgery also during your training. So the concept earlier was the number of adipocytes is determined. So if you suck out the fat globules and adipose cells from the body, then the person cannot put on weight in the same place. That is the concept behind the doing the surgery called liposuction. But now the concept has changed that only up to 40 BMI you can suck out the fat and adipose tissue and reduce the person's body mass index as well as the quantity of adipocytes in the body. But beyond that, what happens? This number increases by the division, multiplication of the adipocytes by division into resulting in what is called clinically severe obesity, formerly called as morbid obesity. So, did you all see the message sent by Dr. Kamachi in the academic group? He had asked 2 questions in that: hypertrophic obesity and hyperplastic obesity.
Yes,
Any
sir.
idea about that? So the answer for that question is in this answer only. So whenever the first part, adipocytes increasing to maximum size, is called hypertrophic obesity, where there is no increase in the actual number of adipocytes in the body. Whereas when the number exceeds because of increase in BMI, then it is called hyperplastic obesity. Okay. So increase in the size of adipocytes alone is hypertrophic obesity. Increase in the number of adipocytes as well as in the size of the adipocytes is hyperplastic obesity. Why central obesity causes more metabolic effect? Why they say that you should not put up a big paunch, your belly should not increase in size? What is the reason? Whether it is for men or women, you should not put on too much fat in the abdominal region. What is the cause for that? What is the reason for that? What are all the ill effects of putting on weight in the central area, the abdominal area? Where does that fat get accumulated? Does it get accumulated only in the abdominal wall or somewhere else also? Have you ever seen a laparotomy being done in obese patient? Have you ever seen the omentum? How does it look like?
Yeah. Yes. Yes,
It
sir.
will be
Yes.
loaded with fat. Omentum
Yes,
will be
sir.
triple the size of a normal person. So storage of triglycerides is regulated by an enzyme called lipoprotein lipase, whose activity is more in abdominal fat than in the fat in other areas like hip or thigh. Okay. Then this is the reason for higher incidence of metabolic disturbances in patients with central obesity. Okay, that is the reason why we must always take care that you don't put on weight in the abdominal area. Now, majority of the obese patients, they develop a condition called insulin resistance. Okay. So how does this, and they become a diabetic even at a very young age. In our case scenario also, I have given the patient is a type 2 diabetes patient, but well controlled with metformin. But why should they become diabetic? The main reason stated for that is they develop insulin resistance. And we saw in the earlier class in discussion of diabetes mellitus how insulin resistance occurs. The two methods by which insulin resistance can occur. Is it the same here or is it something different? Can you attribute the same reasons for insulin resistance in obesity also?
So the adipose tissue will become very resistant to insulin.
Yes. So fatty infiltration of pancreas leads to decreased secretion of insulin. So the pancreatic islet cells, islets of Langerhans cells, they are also infiltrated with the excess fat, and that first decrease the secretion of insulin, number one. The second reason, the increase in the size of adipocytes, they also cause blocking the action of insulin, causing the resistance to insulin. And the third reason is adipocytes also secrete inflammatory cytokines like interleukin 1, interleukin 6, and 2 necrosis alpha, which also decrease the secretion of an hormone called adiponectin. And this adiponectin is normally present in everybody to make the insulin action powerful. It is called an insulin sensitizer. Okay. So in our normal system, this adiponectin helps to stimulate the action of insulin. When the person puts on too much of fat, then the adipocytes secrete the inflammatory cytokines, which decrease this sensitizing hormone, adiponectin. So insulin is not stimulated to do its normal effect. That is another reason for the insulin resistance. The fourth reason is leptin, which is also secreted by the adipocytes, which is a hormone for satiety, modulates energy expenditure and food intake by acting on hypothalamus. So this leptin is not secreted properly. So the person does not feel satisfied with the meal. So they tend to overeat. Okay. So that is another reason the intake of calories increases, which also results in obesity. So these are all, I mean, the insulin resistance. More food intake, inadequate insulin release, and inadequate insulin action. All these things make the person insulin resistant and lead to early formation of diabetes mellitus. And what is the role of omental adipocytes in obesity? As I told earlier, the fat does not get deposited only on the abdominal wall. It gets deposited inside the abdominal cavity in the omentum also. And this omentum fat is metabolically very active. So omental adipocyte infiltration by fat causes increased influx of fatty acids and hormones and cytokines. They stimulate liver to produce more low density lipoproteins and apolipoprotein B. These are the two forms of the fatty acids or triglycerides, and this stimulates pancreas to produce more insulin and polypeptides in the earlier stages, then cause diffuse intracellular inflammation. So before the patient becomes insulin resistant, this will be the reaction in the body by the omental adipocytes. So there is an increased production of the subunits of the lipid profile, which stimulates pancreas to produce more insulin. So earlier stages it will be hyperinsulinemia, and then later on it will become insulin resistance. And this hyperinsulinemia is the cause for intracellular inflammation that happens because of the deposition of fat in the omentum. Now, what is the role of genetic factors in causing obesity? which genes or which part of the genetic system is responsible for carrying forward the obesity tendency. Any names you know of? Mutations in the gene controlling the hypothalamic melanocortin receptor. There is a receptor called melanocortin receptor in the hypothalamus of every person, normally which is involved in appetite suppression. So this receptor is important for suppressing our appetite. That is, when you become hungry after you eat, once the food goes into the stomach, there is a feeling of fullness, satiety, and that keeps you appetite free for the next 3 or 4 hours till you digest all the food that you have taken to get the appetite again. So this melanocortin receptor is involved in appetite suppression, and if that gene is mutated, that suppression does not happen. So the person goes on feeling hungry all the time and keeps on eating. That is the reason for eating more and more. And there are mutations in the genes responsible for production of two hormones called leptin and ghrelin, which are diametrically opposite in their action. Ghrelin is the hormone of hunger and leptin is the hormone of satiety. Okay, so when the ghrelin production is more, you feel more hungry, and the leptin production is more, you feel satisfied and you stop eating. So if the production of ghrelin goes higher and the production of leptin comes down, again patient will start feeling hungry all the time and keep on eating, and will overeat every time, and that will be deposited as fat because he doesn't do adequate expenditure to digest or remove the calories. So these are the two reasons: the mutations in the gene controlling melanocortin receptor and homozygous mutations of both leptin and ghrelin secretion and their receptor activity are considered as. This is the reason for childhood obesity also. Now, how do environmental factors contribute? What we saw is the genetic factor. What are the environmental factors which contribute to obesity?
Stress
What
hormone.
That's psychological. That is about increased consumption of high calorie foods and decrease in physical activity, especially nowadays with all the junk foods that are available, pizza, burger, everybody is fond of that, and all of them have a huge amount of calories, especially children. All the time they want only pizza and burger, and if you eat more of them, the calorie intake becomes more. Then the psychological and socio-economic factors is the causation for obesity. So eating disorders which are linked to depression, people who are depressed and psychologically in a low mood, they ward off the depression by eating more, and that is called binge eating syndrome or night eating syndrome. Most of the people nowadays who work in the information technology, IT people, because of their odd hours, they eat at 2 a.m., 3 a.m. I have seen somebody having full-fledged dinner at 5 a.m. because of their work timings. So all these things gradually lead to the person becoming obese. Now, what are the endocrine pathologies that can happen in obesity? Which are all the endocrine organs which can be either causative for obesity or get affected because of obesity?
Metabolic syndrome.
We have seen metabolic syndrome, diabetes mellitus. These two can be caused by obesity itself. But Cushing's syndrome and hypothyroidism, they may contribute to obesity. Patients who have this hormonal defect in Cushing's syndrome and hypothyroidism, they become obese because of the activity of the hormones. So the obesity can be caused by endocrine pathologies, and some endocrine pathologies are caused by obese patients. where they did not have that pathology earlier. So metabolic syndrome and diabetes mellitus occur only when you put on weight, whereas Cushing's and hypothyroidism, they make the patient become obese because of the nature of the hormonal imbalance. Now, what are the gastrointestinal pathologies associated with obesity?
GERD. sir.
Delayed gastric emptying.
Delayed
GRD.
gastric emptying, GERD.
So GERD. Raise the liver enzyme profile.
Steatohepatitis.
Steatohepatitis, very good. Non-alcoholic steatohepatitis, they can have mechanically hiatus hernia, they can have fatty liver, they can develop gallstones, and they can have GERD, gastroesophageal reflux disease. So when you take the history, you must ask for the features of all these things. That is the reason why I am describing all the pathologies one after another. And what are the musculoskeletal disorders common in obese patients? The various.
Prevalence of early osteoarthritis.
Very good. So osteoarthritis, backache, sometimes they can develop inguinal hernia because of poor muscle strength. As I told you, sarcopenic obesity, their muscles are weak, so they can develop inguinal hernia more commonly. So that is the muscle part of it. Skeletal part of it is OA and backache, spinal problems. So what malignancy can occur in obese patients? Which malignancies are common in obese patients? They are prone for malignancy also.
Uterine cancers.
Uterine, female uterine, ovarian. The commons are pancreas, kidney, breast, prostate, uterus, and colorectal. Okay, all these cancers can occur simply because the patient is obese, because of the chronic secretion of inflammatory cytokines leading to mutation of the cells leading to the malignancy. What are the other ailments associated with obesity? Commonly are kidney failure, depression, shortened life expectancy. Okay? These are also some obese people suddenly die. So sudden death is one of the classical feature of morbid obesity. Now, important for us are the respiratory and cardiovascular system disorders that occur in obesity as anesthesiologists. So we should know thoroughly what are all the respiratory system disorders that can occur in obesity. Can you enumerate the respiratory system disorders?
Yes, sir.
Obesity,
There will be decrease
hyperinflation.
One
in
at a time.
FRC.
The
Decrease in
FRC.
FRC and poor lung compliance can be expected, sir.
Okay. So what type
Respiratory.
of respiratory problem they will get? Obstructive, restrictive,
Restrictive pattern.
Restrictive type of.
restrictive lung disease due to added weight in the chest wall, thoracic cage, and abdomen. That is the most common because too much of fat is deposited under the skin, which is pressing on the chest wall, not allowing the rib cage to expand well during inspiration, and causing limited expansion of the alveoli inside the thorax. Okay, so that is the first thing. Decrease in FRC due to impedance of descent of diaphragm, which can cause early desaturation, and decrease in ERV and total lung capacity. Both are decreased, and closing volume may later on gradually exceed FRC, leading to ventilation perfusion mismatch, which will lead to right to left intrapulmonary shunting, leading to arterial hypoxemia. And why pre-oxygenation is very important in obese patients? Once you know that the FRC is decreased, you must know this answer also, because it's commonly asked in the examination why pre-oxygenation is more vital in obese patients than in normal patients.
The ability to tolerate the apnea will be less because of decreased
Yes.
FRC. So
Because the reduction in FRC is 50% compared to the normal healthy person, which is only about 20% in non-obese patients during induction of GA. So that is the reason these people will desaturate much faster. So the safe apnea period is very shortened in obese patients. So the pre-oxygenation becomes very important. So it's very important to pre-oxygenate obese patients before GA to prevent desaturation and prolong the safe apnea period. Okay. Now, what is OSA? What is the expansion for OSA?
Obstructive sleep apnea.
Obstructive sleep apnea. Okay. Some obese patients. And how do you define OSA? What is the definition of
Cessation of breathing for more than 10 seconds.
total cessation of breathing for more than 10 seconds, which occurs episodically. It is not a continuous one. So it occurs episodically in some obese patients. Not all obese patients will have that, but you have to ask every obese patient coming to you for pre-anesthetic assessment whether they snore first of all or whether they get obstructed and wake up. How do you, what questions you will ask to find out whether they are having OSA or not?
Top bank score.
Top
Snoring,
bank questionnaire
tiredness.
is one. But before that, what is the simplest question that you can ask? First thing, always ask whether the person snores or not. Okay, that snoring is always associated with OSA. Nobody goes into OSA so in a very silent, quiet way. So snoring will be very common. And then if you ask the patient, do you get choked and wake up in a startled fashion in the night? Then they will say, yes, I have experienced that. Even if they are not, many patients who are having OSA are not aware that they are having that problem at all. So it is better to ask the partner or somebody who is living in the house along with them to find out whether they get woken up by the obstruction and feel startled and then resume their sleep after a few minutes. So that is a very important question that you should ask. So cessation of breathing for 10 seconds or more during sleep in an episodic fashion is defined as obstructive sleep apnea. What are the symptoms of OSA? What symptoms usually a patient who knows that he is having OSA, what are all the symptoms he will be able to describe to you?
Loud snoring, and unrefreshing sleep in the morning, sleep disturbance, and tired in the morning.
Daytime somnolence, that is a very important part of it. Daytime somnolence, impaired concentration and memory, headache on waking up. These are the three classical features of OSA. They feel more sleepy during the daytime and they are not able to concentrate in their job and they have memory loss and they wake up with a headache. Even though if their blood pressures are normal, they are not hypertensives and they don't have any visual acuity problem to get a headache. It is purely because of the disturbed sleep they wake up with a headache. So what is OSA syndrome? Is there any terminology called OSA syndrome?
Pickwickian syndrome.
And Pickwickian syndrome is different. Pickwickian syndrome is short-statured, pot-bellied, hypoxic, hypercarbic patient is a Pickwickian syndrome. But patient with OSA and classical daytime somnolence, that is called OSA syndrome. So if the patient is all the time sleeping during the day, then along with that, if he has this obstruction during night, these two combinations is called the OSA syndrome. Obstructive sleep apnea with a very prominent daytime somnolence is called OSA syndrome. Okay? Now, what is top bank questionnaire and what is its use?
It was used to quantify the grade of OSA.
Very good. What are all the components of this acronym, top bank? S for what?
Snoring,
Snoring,
Tiredness, observe.
tiredness,
O for any observed choking or gasping during the sleep.
obstruction, very good. P
Uh,
for
B, B for blood
Blood
pressure,
pressure.
whether
P
they are on
for
any hypertensive.
P for pressure. Okay. B
B for
BMI.
BMI of more than
BMI.
35,
More than 35.
Age,
Age more than
age
50.
of more than 50,
N
Neck circumference more than 40. Gender male.
40. Gender male. Very good. So stop bank questionnaire helps in clinical confirmation of OSA and also to grade the severity of OSA. Both it can be used. So the components are snoring, tiredness on waking up, obstruction as noticed by family members, and pressure, hypertension. And the bank BMI more than 35, age more than 45, neck circumference more than 40, and male gender. All these things indicate whether the patient has confirmation. What is the gold standard test to confirm OSA?
sleep study,
Polysomnography.
Very good.
Polysomnography.
Subjective confirmation is done by overnight polysomnography. Okay, it is called overnight polysomnography. But nowadays they have reduced it to even 2 hours, 3 hours polysomnography also. Earlier it was started as overnight polysomnography. And how do you classify sleep apnea? Is there any classification of sleep apnea?
Based on the apnea
That is the duration, whether it is a full apnea or partial apnea. That is hypopnea and apnea. Total apnea, cessation of breathing happening. What are all the causes? How it can be classified based on the causative factor? It is classified as central and peripheral. Okay. If the sleep apnea, even a stroke patient can develop, even if they are non-obese, patient who has suffered a stroke because of the involvement of the respiratory centers in the higher level, they also can go in for this periodical cessation of breathing. Or patients who are overdosed with opioids, they also can go for cessation of breathing periodically. All these things are caused as central sleep apnea, whereas the obesity induced sleep apnea, which happens at the periphery level, at the upper airway level, that is called peripheral sleep apnea. So central sleep apnea, there is no respiratory effort at all, and it's due to central respiratory center depression. Whereas if you watch the patient with a peripheral sleep apnea, they will attempt respiration. Their abdominal movement will be there, but no airflow will occur because the airway is totally collapsed. So that is the way to mainly distinguish or differentiate between a central sleep apnea and peripheral sleep apnea. In central, there is no respiratory attempt at all. The abdomen will be quiet and they will be choking. Whereas in peripheral, you can see a small flicker of the abdominal muscles trying to initiate a breath, but no airflow occurs because of the collapse of the upper airway. Now, how is polysomnography done? What is the method of doing it? Do you have to admit the patient to hospital or can you do it in home itself?
home also is available.
Earlier, it was compulsory that patients should get admitted in the hospital because they have to fix all the monitors. Various monitors are attached to the patient to record the various changes. So it was made compulsory. But nowadays, they prefer to do it at home setting because patient will have a more natural sleep at his familiar place like his home and bedroom. So you can attach all the monitors. After all, you are not going to do any interventions here. All you want is to record the parameters. So the same monitors can be attached and the whole recording can be done in the home setting itself. So that is the improvement that has been done in polygraph study. So first thing, earlier it was patient admitted overnight in the hospital and his entire sleep is videographed. This is the most important part of it because they want to see what is the position in which the patient sleep. Majority of the patients with OSA, can you make a guess in what position they would like to sleep?
Using two pillows or head up position, like a ramped up position.
No. They mostly sleep on the lateral or in the
Lateral.
prone position. Okay, unless they have a very huge paunch where they cannot lie full prone. Majority of them will lie only on the lateral position because they get easily choked when they lie in supine position. Even if you keep two pillows, it will not help. So it is mostly the lateral, right lateral or left lateral, and some people somehow manage to go to the prone position also to get over this problem of obstruction. So to videograph that position is very important. Then the monitors that are attached are EEG, ECG, pulse oximeter, electrooculogram. What is the purpose of this electrooculogram?
To record the eye movements.
To see whether the rapid eye movement and non-REM sleep. Okay,
REM
we
and
said
non-REM.
earlier class we read about what is the type of sleep, how it is induced. So there is always a cycle between REM and non-REM sleep. So that can be detected only if you attach what is called an electrooculogram. Then chin electromyogram, which will tell you about the laxity of the chin muscles, airway microphone, then elastic belts over chest and abdomen to monitor respiratory efforts, and two-leg EMG to monitor leg movements are attached, and recording done for 6 hours while patient sleep. So these are all the monitors that have to be attached. How does polysomnography help in OSA treatment or diagnosis of this condition? What are all the things it will record? When you attach all the monitors, what parameters do you record?
Heart rate, SpO2.
These are all general. With regard to OSA, how many times he is obstructing? Okay, how many apnea episodes are
hypopnea.
there? So PSG helps to diagnose central, peripheral, or a mixed types of sleep apnea. Number one, it also identifies the severity as mild, moderate, and severe using what is called the apnea hypopnea index. Okay, 60 to 26 to 20 considered as mild. If the apnea occurs between 21 to 40, it is considered moderate. More than 40 times of apnea is considered as severe. So you can assess the severity. It also measures what is called the arousal index. So using these two, apnea hypopnea index, which is also the short form called as AHI, and arousal index, which is also called AI, the short form. What other index can you deduce from these two findings? What is the name for that? My dear? So it is called respiratory distress index. Okay. So respiratory distress index is nothing but the addition of apnea hypopnea index to plus arousal index. If you join both, then you get what is called respiratory distress index. Now coming to the CVS, what are all the CVS effects of obesity? What are all the changes that can happen in the cardiovascular system of obese patients?
Hypertension.
Hypertension, very good. Coronary artery disease.
Rectal dysfunction.
Biventricular failure.
Failure also. So systemic hypertension is due to insulin effects on the sympathetic nervous system and also extracellular fluid volume. These are the two reasons for systemic hypertension. Then adipocytes activation leads to release of angiotensinogen, which activates renin-angiotensin-aldosterone system pathway, which results in sodium retention, which is also the reason for the development of hypertension. Then cytokine release, they damage the arterial walls, leading to fibrosis and stiffness, leading to hypertension. So these are all the reasons why a obese person will develop hypertension. And uncontrolled hypotension will lead to concentric and eccentric left ventricular hypertrophy, which may result in heart failure as well as in pulmonary hypertension. Now, are these changes reversible or irreversible? This hypertension change, should it be treated only with medication or can it be reversed?
Initial stage can be reversed.
Yes, weight loss can completely resolve hypertension. So that is the reason why you must always advise people who are overweight or obese to reduce their weight. How much increase in cardiac output can happen during weight gain? When you keep on putting more and more weight, for every kg increase in weight, how much the cardiac output will increase? This may be a OSCE question. Just make a guess. How many ml per kg increase has to happen? Increases 100 ml per minute for each kg weight gain. Okay, so that is the reason why your heart also has to work more. So 100 ml per minute has to increase for every kg increase in beyond your normal weight. Okay. What is the cause for coronary artery disease in obesity?
Diastole dysfunction.
Diastole dysfunction means the heart is not able to relax well. So the left ventricular filling will become inadequate. So in obesity,
Atherosclerotic deposit.
Chronic inflammatory state, dyslipidemia, hypertension, and early onset of diabetes mellitus. These are the 4 pathological changes that happen in obesity, which also lead to coronary artery disease because of atherosclerosis formation in the coronary vessels. Chronic inflammation, dyslipidemia, hypertension, and DM. So DM also causes progressive atherosclerosis. So all these things lead to early coronary artery disease in obesity. Now comes one of the important short note questions for theory, metabolic syndrome. What is metabolic syndrome? What are the other names for this condition? What are the components of metabolic syndrome?
Rise in triglyceride level of more than 150 milligram per deciliter. Rise in waist hip ratio.
So metabolic syndrome is also known as syndrome X, okay, or also known as insulin resistance syndrome, or also known as Rehaven syndrome. Okay, Rehaven is a person. Gerald Rehaven is a person who was a cardiovascular specialist in Stanford University, and he only investigated and found out that patients who develop insulin resistance develop this metabolic syndrome. Do you know why it is called syndrome X? There's a small story around this also. Earlier, when Rehaven was investigating about metabolic syndrome, they did not know what is the factor causing all the changes because of obesity. So in mathematics, whenever you don't know a number, you keep it as X, isn't it? Later on, you find out X is equal to, you do the calculations and then you try to find out the answer. So he kept it as X. Then later found out that it was insulin resistance which was causing all the problem. So it is named as syndrome X because initially they were not aware why this problem happened. So the other names for this metabolic syndrome is all these 3 names. and it is characterized by increase in waist circumference. That is, they should have central obesity, they should have hypertension, insulin resistance, decrease in HDL. What is HDL? High density lipoprotein. Is it good cholesterol or bad cholesterol?
Cholesterol.
It's a good cholesterol, high density. Even though the name looks like it is high density, it is good cholesterol. So that also decreases, and increase in triglycerides. So these 5 components, they are the characteristics of metabolic syndrome, but it is not necessary that you should always have all the 5. Any 3 out of the above will qualify the person to be called as metabolic syndrome patient. So increase in waist circumference, hypertension, insulin resistance, decrease in HDL cholesterol, and increase in triglycerides. Any 3 of the above will constitute metabolic syndrome. Now, what is the significance of this syndrome? Why should we be worried about this? If a person coming to you for this, for example, this lady who has come for total knee arthroplasty, if she has a waist circumference, it should be normally only 88 centimeter for a female. It is say 110, and she has hypertension, and she has decreased HDL or increased triglycerides, and she qualifies as a person to be called as metabolic syndrome patient. What are the dangers associated with that? So these patients are prone for sudden death. Okay, so always remember, whenever an obese patient comes for an incidental surgery or a obesity treatment surgery like a bariatric surgery, always rule out metabolic syndrome in that patient before you take up that patient, because there have been several reports where preoperative assessment was okay, airway was manageable, blood pressure was under control, patient had a smooth intraoperative course of surgery, but 4th day, 5th day, they suddenly collapsed and died. This is what is the common scenario that will happen. So make sure that you look for metabolic syndrome and document it in your pre-anesthetic assessment, so that if sudden death happens, it is one of the agreed complications of metabolic syndrome. So if you have failed to document this, if it is present in the patient, then you will be in trouble. So always look for these 5 things and record it, and make sure that the patient is not coming under the category of metabolic syndrome. Now, how to treat obesity? This obesity treatment also have some relevance to us as anesthesiologists. When we want to take up the patient for surgery, we should be aware how we are going to treat this patient. So what are the basic steps in the treatment? Supposing obese patient in your own relative comes and asks you as a relative doctor, please can you guide me and advise me about the treatment, how I can reduce my weight? What will be your advice?
The lifestyle changes can be done.
Very good. Patient motivation is very, very important. So just like an alcoholic who wants to quit drinking, unless he himself has got the inclination to stop that habit, it's very, very difficult for you to cure an alcoholic addict person. So similarly, a obese patient should realize that they are obese and they should make sincere efforts to reduce the weight. So motivation of the patient is very important. The first thing is diet restriction. They should reduce 500 to 1000 kilocalories from their regular diet. So you ask them to enumerate what is all their diet habit, what are all the things that they are eating, and calculate how much total calories they are taking. And from that calorie, you try to reduce at least 500 to 1000. Then ask them to go for regular exercise. Then what is the medical therapy that is used to treat obesity? What are all the drugs that are used? There can be serotonin and norepinephrine uptake inhibitors, which are widely used earlier, but now withdrawn due to the side effects. Some of you would have heard the name phentermine. and fenfluramine or sibutramine. These were the drugs that were previously prescribed as medical management for obesity, and they used to do act by serotonin and norepinephrine. They are like the drugs used by psychiatrists to as a mood elevator and to treat some of the psychiatric conditions. They also have the same mode of action, serotonin and norepinephrine uptake inhibition, and but they have lot of cardiovascular side effects, so they are nowadays not prescribed. And it is mainly they cause appetite suppression. So their mode of action is to suppress the appetite, so patient will eat less, calorie intake will come down. But orlistat is one drug which is still prescribed, and the patients are allowed to take, and this decreases fat absorption. It is almost, can you compare any drug in diabetes usage to this particular orlistat?
The liraglutide, metformin.
Liraglutide is a parenteral drug, but orally given drug, which will prevent
Metformin.
absorption of glucose.
Metformin.
Here, the metformin enhances the formation of glycogen and utilization at the tissue level. It does not suppress or decrease the absorption of glucose. Have you heard of acarbose?
Acarbose, yes sir. Yes, sir.
So that drug prevents the absorption of glucose from the gut, thereby it prevents the hyperglycemia occurring. Similar to that, here orlistat prevents the absorption of fat from the diet, and that is how it also reduces the blood fat level and decreases the accumulation of fat. So ephedra is one of the trade name which causes increase in energy expenditure, which is an over-the-counter medication, but that also has a lot of serious side effects. So these are all some of the names that you have to know before you go for your exam, because some examiners may ask you about any medical management. So phentermine, which is not used, orlistat you have to remember, it is a anti-lipase. It prevents absorption of fat from the gut, and ephedra, which is a non-prescription drug. Now, what are the surgical options as a treatment for obesity?
The sleeve gap, they can be restrictive pattern and two types of surgeries, something there.
Malabsorption surgery.
Malabsorption.
So they are called bariatric procedures, mainly to treat obesity, and also in patients who are very resistant to anti-diabetic treatment because of obesity. One of the indication nowadays for bariatric surgery is to cure their diabetic state also. So patients who lose weight after bariatric surgery, their diabetic state gets very well reversed. So patients who become very severe diabetic, who do not respond to even insulin injections because of obesity, they get cured of their diabetes if they lose weight after bariatric surgery. So the two indications for bariatric surgery, one is morbid obesity causing physical and cosmetic problems. The second is very resistant diabetic because of obesity is also one of the now indicated reasons for surgical therapy. What points in history are important in preoperative evaluation of the obese patient? What are all the points you should look at? Now this 31-year-old lady has come to you for TKR. So how will you start examining this patient? Which are all the systems you will look for? We have seen now all the pathologies that occur in various systems because of obesity. So you should keep that in mind and start examining the patient. So history should focus on first cardiovascular system, whether the patient had any chest pain because of coronary artery disease, shortness of breath at rest or minimal exertion, palpitation. Then coming to RS, whether they have symptoms of obstructive sleep apnea, snoring, whether they are using any CPAP or BiPAP, what is their exercise tolerance level, then any previous surgery, history of DVT is very, very important. Obese patients are more prone for deep vein thrombosis, and whether they have gastrointestinal problem of GERD. So these are all the basic minimal system-wise questions that you should ask from the history. And whether they have hypertension and whether they are on treatment, that also can be used, and medications and how their morbidities are under control. If they are diabetic, in this questionnaire, in the case scenario, I have given that this patient is known type 2 diabetes but well controlled with metformin alone. So hypertension, what medications they are taking, are they taking any anti-anginal medications? So all these questions should be asked. What should be focused in physical examination? So after history taking, what should you focus in the patient's physical examination? What is the first priority you should look for?
Airway.
Airway, very good. First and foremost, check for serious RS involvement. Then airway examination to predict difficult airway, both for mask ventilation and intubation. This is a very, very, that is why I have given it in red in highlighted way. So please remember, airway examination in obese plays a very, very important role. And peripheral venous access. A very, very severe obese patients, it will be impossible to find a vein in the arms. So peripheral venous access should also be checked for in the physical examination. And if they have had any DVT history, whether any IVC filter is needed before you take up that patient. It's also important thing that you should check for. What are the investigations needed in obesity? Majority of us do all the investigations for any surgery. But is there any special investigations needed in obesity apart from the routine one?
The echo can be asked for a safety purpose.
We are doing echo for everybody, no? So routine blood test, LFT, RFT, and coagulation profile is very, very important. And ECG for evidence of LVH, RVH, or ischemic heart disease. CXR for heart and lung, echocardiogram for heart chamber dimensions, systolic and diastolic function, and pulmonary hypertension. This is a very important point you should look for in the echo. Because of the chronic restrictive lung disease, they may develop pulmonary hypertension quietly and go for biventricular failure, as somebody mentioned earlier. And also look for polysomnography if it is diagnosed for the first time. So patients who are not aware that they have this problem, and you find that from the patient's history that they get woken up in the night, they have morning headache, they have daytime somnolence, then you should ask for a polysomnography and assess the severity of the apnea. And respiratory distress index should be calculated, and the grading, whether it is a mild OSA, moderate, or severe OSA. If it is moderate to severe, treatment should be initiated in the preoperative phase itself for all elective patients, either with a CPAP or a BiPAP. You should ask them to take that treatment for at least 2 weeks to 3 weeks, and then only take up the patient for surgery. And of course, ABG in breathing wear will tell you if they have OSA, whether they go for desaturation and hypoxemia, or whether they are developing hypercarbia also, which is common in the so-called Pickwickian syndrome. Now, what are the pre-op instructions you should give for obese patients? This is just like for anybody else. So continue home medicines except the oral hypoglycemic agents, AC inhibitors or ARB, and antiplatelet and anticoagulant drugs, which have to be titrated or adjusted the timing. Then you must order for NPO for all elective cases, and you must give anti-aspiration prophylaxis for all obese patients. And if they are using CPAP or BiPAP, this is a very important pre-op instruction. They should be asked to bring those equipment to the hospital when they come for surgery. Okay? And if they have any previous history of DVT, you must start using heparin or low molecular weight heparin according to the nature of the surgery. You must time it and start that pre-operatively itself. Now, how do you plan for the intraoperative management? Especially a morbid obese patient like our case history, where the patient is 46 BMI. What are all the intra-op management plan you should do? You cannot just like that post the patient and like a routine case, you cannot go to the OT and start doing the case. So you must have some pre-op planning for the intraoperative management. So that should be first decide whether you are going to do it under regional or GA based on the airway, patient position, duration of surgery. For our case, where it is a TKR procedure, what anesthesia you would prefer?
Regional, sir.
Regional, very good. Regional, of course, is much more safer in these patients than GA. Why regional is preferred? What are the advantages of regional anesthesia in obese patients?
Postoperative lung complication will be less.
Okay. Then
We can limit the post-operative opioid use, sir.
okay, very good.
We can reduce the ICU stays if not muddled with the airways and everything.
First and foremost, SAB, epidural, that will perform in the sitting position, or nerve blocks and plexus block have the following advantages. One is, first of all, we are avoiding airway manipulation and aspiration risk. Okay, whenever you try to give GA for obese patient, especially with a anticipated difficult airway, this is also going to be a challenge because they can desaturate easily or have aspiration problem. So by choosing a regional technique, you can avoid airway manipulation and aspiration risks, number one. Number two, less use of opioid drugs, so less respiratory depression because these patients are more sensitive to opioids, and you have to give opioids in a larger amount because of their body weight. So that may lead to central nervous system depression and respiratory depression. But what are the disadvantages of RV in obese patients?
Difficult landmarks, sir.
Excellent. So technically challenging since landmarks are obscure. Then
Positioning will be difficult.
limited duration of anesthesia. So you have to either resort for a continuous technique. For example, your TKR, your surgeon is going to take 4 hours instead of the normal 45 minutes to 1 hour done nowadays by expert surgeons. If they are going to do it for 4 hours, your single shot spinal may not work for that long. So unless you do a continuous epidural catheter or intra-subarachnoid catheter, you cannot prolong the anesthesia. So limited duration is the second disadvantage. And patients who are very obese, they will not be comfortable to lie flat for longer procedures. Okay, so they may require sedation, and if you give sedation, there is a chance of airway obstruction, especially if they have OSA, you cannot give too much of sedation also. So the third problem is the position. And what is the most important precaution needed before choosing RA? What is the important caveat or the caution that you should exercise before choosing? Just because it's TKR, you cannot take it lightly that it can be done under spinal or epidural and get away with that. What is the most important precaution? Most important precaution is
Backup plan for
never attempt RA unless confident of converting to GA if the need arises. This is a very, very important dictum that you should keep in your mind so that you can avoid any catastrophe. Never attempt RA unless you are confident of converting to GA if the need arises. Okay. So what points to be checked for intra-op management? For that, you are planning general anesthesia. All the team members should be familiar with the problems of managing obese patients and should be able to perform their role properly. This is a very important thing. Obesity surgery, especially patients who are very morbidly obese and they come for surgery, you cannot do it alone as a single person. You have to have a good teamwork. There is a important guidelines given by the Obesity Society of UK in the Anesthesia Journal of published by the Association of Anesthetists of Great Britain and Ireland. One of the issues they have given a 10-point guideline how to manage morbid obese patients. Please go through that, it's available in the net. So the first point they say is it should be a teamwork and all the team members should be familiar with handling the obese patients and they should know what is their individual role. And pre-medication only with the drying agents with anticipated difficult airway. Don't give any sedative or narcotics to these patients, especially if they have history of OSA. Avoid sedative and narcotic pre-medication. Avoid class 3 obesity patients may need larger operating tables. So you should plan and make sure that those tables are available in the OT. And transfer of patients from trolley to OT table may be a challenging issue unless special rollers are available. So you should keep all those modes of shifting the patient from many hospitals where patients can walk. They bring the patient supported by asking them to walk themselves and then bring them to the OT table and ask them to lie. Instead of trying to bring them in a wheelchair or in stretchers. So patients, that is the reason why you avoid any sedative pre-medication also. So you can ask them to walk. For example, if the patient is 200 kg, you cannot even try to shift him in the trolley or the wheelchair. Then side support should be checked and fitted properly, especially if the patient is not going to be in supine. He is going to be in head down or head up tilt or lithotomy. All support should be checked and fitted properly. So this picture gives you an idea how this obese patient is brought in a special wheelchair and how she is shifted into the ambulance and how the patient is positioned for a spinal sitting posture, how the patient is kept in a head-up position for a laparoscopic surgery. You can see all the supports here, the belts that are kept to keep the patient tight, and the lithotomy. So these are all the things which should be checked and kept ready. So this is called the intraoperative plan. And how do you manage a patient with anticipated difficult airway? What are all the preparations that you should do? Of course, for any anticipated difficult airway, there is an algorithm that you have to follow. But in obese patients, what are all the things that you have to keep ready? It's a practical exam. Keep the difficult airway cart ready. Very good.
Senior anesthetist presence can be.
Helping hand is very, very important. That is the first and foremost thing. A sensible helping hand, either in the form of a senior anesthetist or a good OT technician who is knowledgeable enough to help you for giving a burp or the compression or guiding a bougie. All these things requires a helping hand. So first you can do the patients in a ramp or held position is ideal. Difficult airway cart should be checked and kept ready. Skilled assistant to help with burp maneuver or a 2% mask ventilation is very essential. Cricothyroidectomy kit also to be kept ready in case any problem ultimately leading to front of neck access. You have to keep, you should not be searching for this kit at the last moment. And ENT surgeon presence in anticipated difficult airway is also very, very important. Okay, so these are all the steps that you have to keep in mind. And if definite difficulty is anticipated, plan for awake fiber optic intubation. Okay, so you can do the intubation when the patient is awake and then proceed with the surgery. How is the correct RAM position assessed? Place the patient in RAM position. What is the landmark, or how will you say that the position has been done correctly? What are the two landmarks that should be connected in RAM position?
The sternal notch and external auditory meatus.
Excellent. Very good. So this is the bad position. Here you can see the head is low and the three angles are not parallel to each other. It's crisscrossing, oral pharyngeal. So airway access, aligning on head cradle only. Whereas if you keep the RAM position, there is a special pillow, it should go under the shoulder also, and there is a headrest. So if you do that, the external auditory meatus and the suprasternal notch will come in the straight line. Okay, so this is the correct good positioning. So this is how you should always, after placing the patient in RAM position, you should go to the side of the patient and see the lateral view from the side and make sure that the external auditory meatus and the suprasternal notch are in the same line. Here you can see it is going in the oblique way. It is not in the parallel straight line. So this is the correct RAM position that has to be done. What are the challenges in monitoring of an obese patient during surgery? Which are all the monitors which can be giving you trouble?
BP cuff.
BP cuff,
BP
sir.
cuff, yes. First and foremost is NIBP. So you need an extra large cuff. In the absence of standard cuff, can be tied in the forearm, or you can put, very difficult means you have to go for intra-arterial invasive line. And ECG lead placement should get maximum size complexes. So you must fix the leads and make sure that the ECG tracings are well seen. And these patients usually become very hypothermic. And hypothermia can delay the emergence as well as have other complications like coagulation problem, wound healing, and all those things. So temperature monitoring becomes more important, and urine output also to be monitored for adequate perfusion and fluid status. Okay? And pressure points to be padded properly. This is very important because their large mass and the prolonged surgery, they can easily get a pressure sore. And preventing patient sliding from table by proper restrainers is also very important. So this is how you tie the BP cuff in the forearm. If the cuff is smaller for the, you don't have the extra large cuff, then you can tie the regular standard cuff that you use for other patients in the forearm and try to do that. And this is how you restrain the patient from sliding down the table. What are the steps during induction of GA in obese patients? Supposing you plan to give GA for a patient, what are all the steps that you have to follow? Every day GA, what are the things that you do for? What is the first
Weight-based
thing
in
that you want?
graded doses of hypnotics can be given, sir, instead of
No.
they're opioid sensitive and
No. In your regular everyday GA, what is the first step in your starting GA?
IV access.
IV access. Secure proper IV access, either peripheral or central. That is the first step. Some hospitals, because in the ward itself, some nurse will start the line and then you don't think about it. But during our postgraduate days, we only have the anesthesia PGs only will have to start the IV access. We never allowed the nurses in the ward or anybody to do that. So always they used to call the anesthetist for help to get the IV access. So first and foremost step is to get the IV access. then place all monitors securely, because especially if the position change is there, unless you have fixed the ECG leads properly, there is a possibility it can get removed and get slipped. So place all monitors securely. Then pre-oxygenation is very, very vital. Before GA, pre-oxygenation is very vital, and assistance to help in securing the airway is also very important. And patient should be head in the ramp position. So those are the first initial steps during induction. Now comes, how do you calculate the doses of the various drugs used? What are all the weight that you want to know? Is there only one weight for an obese patient, or there are different weight calculations?
There is total body weight and lean body weight, sir.
Ideal body weight also we saw.
Ideal.
Height in centimeters minus 100 is ideal body weight. So there are 3 body weights. One is total body weight, then second is the ideal body weight, third is the lean body weight. So what is the difference between ideal body weight and lean body weight? Ideal body weight plus 20% of the ideal body weight is called lean body weight. Okay, so total body weight is the actual weight that you measure, and then the ideal body weight is calculated by height in centimeters minus the 100 or 105 for male and female. Then if you take 1/5 of that ideal body weight and add that to ideal body weight, it becomes lean body weight. So some drugs have to be given on total body weight and some drugs have to be given on lean body weight. Okay, so that is the reason why you should calculate both the total body weight and lean body weight for the patient. So if you do induction by propofol, you have to give the drug on a total body weight basis. IV for a single induction, for example, if our patient is weighing, let us say 120 kg, then you have to give 2 milligram per kg body weight, 240 milligrams of propofol has to be given for IV induction. On the contrary, for intraoperative use, or if you are going to use as an infusion, instead of using some volatile anesthetic agent, you use propofol infusion. For bariatric surgery, some anesthetists have the practice of using propofol as an infusion throughout the surgical procedure to maintain the unconscious state. Then you can calculate the dosage on lean body weight basis. Okay, and suxamethonium again you have to give as total body weight, and non-depolarizing muscle relaxants like atracurium, loading dose is also on lean body weight, but maintenance later on, I mean total body weight and maintenance lean body weight. Fentanyl is given only on lean body weight basis. Okay, so these are the common drugs that we use, which are given on various body weight percent. And all lipophilic drugs tend to have a long duration of action if given at total body weight. So it is better to use them on lean body weight basis rather than total body weight. Now, how is intraoperative airway management done in obese patients? Do we have to intubate them all the time, or is there any other choice? So airway can be secured preferably by ET tube or by third generation LMA, which should have a gastric port for removing any secretions or any gastric contents which are likely to come out. So third generation LMAs are only safe for use in this patient. What is the preferred mode of ventilation during surgery? We are going to use a ventilator for intraoperative ventilation of the patient.
Pressure control mode.
Very good. Pressure control. What other things you should add in that?
Pressure control, volume guarantee.
Volume guaranteed. Then
PEEP
what
should
about
be
the IV ratio?
PEEP should be
PEEP
added.
also should be, yes. Controlled ventilation using pressure control with suitable PE ratio to minimize peak airway pressure and PEEP to ensure adequate oxygenation. Okay, so these are the things that you have to remember. And you can use a combination of oxygen, air, CO, or desflurane, and monitor neuromuscular paralysis to titrate neuromuscular blocking drugs. Otherwise, you will end up with overdosage. And the TIVA or TCA using remifentanil or dexmedetomidine is advocated for bariatric surgery. Any other combination which is also preferred and recommended, especially for bariatric procedures? Ketamine and dexmed infusion, that is also recommended as a best method for bariatric procedures. How is the fluid requirement calculated? Is it calculated on total body weight or ideal body weight or lean body weight?
Lean body weights.
It should be only on lean body weight. Okay, don't give on total body weight because their total volume is low. So rapid infusion will cause overloading and pulmonary edema. So never give too much large volume based on the total body weight. It should only be on lean body weight. What are the precautions you have to follow during emergence? The end of general anesthesia, during emergence, what are all the precautions to be taken in obese patients?
Patient should be
What
fully awake and alert before
Very good.
extubation.
Very good. What should be the
Preferably in
position of the patient?
head up position,
Position.
airway
good.
exchange catheter or LMA can be used as a bridge for extubation.
Very good. Towards the end of surgery, when spontaneous respiration renews, position of the patient should be semi-upright. Why this is important? Why should you keep the patient semi-upright? What will you gain by keeping this patient in the head up tilt position?
I think it can
FR
prevent the
Increase the
upper airway.
FRC, sir.
Basal atelectasis and decrease in FRC can be to some extent reduced. Okay, so that the diaphragm will go down and patient will have a better excursion or expansion of the lower bases of the lung. Otherwise, they may develop basal atelectasis. And use pressure support ventilation with PEEP before reversing neuromuscular blockade. Okay, when they spontaneously breathe, if your ventilator has got a pressure support mode, with PEEP you switch on to that. And extubation is carried out in the upright position, almost vertical, 90 degrees up. When the patient is fully conscious, alert with no signs of depression due to volatile agents or narcotics. And transport to high dependency unit or ICU in the same upright position with oxygen supplementation, pulse oximetry monitoring, and verbal contact to assess the wakefulness. Because especially if they have OSA and they become drowsy, they may hypoventilate. And there are cases reported where patients have arrested before going to the PICU or HTU. So keep talking to them and keep them in a wakeful state while you are transporting such patients. How to manage post-op pain in these obese patients?
Minimize the use of narcotics since they are sensitive to opioids.
Very good.
We can go with the other.
It's called multimodal analgesia. Please remember this terminology in all your core theory exams as well as in practical exam. Whenever they ask about pain management, first use the word multimodal analgesia, using either a block or a regional technique like epidural, epidural. Then go for non-opioid drugs like NSAIDs, alpha-2 agonists, NMDA antagonists like ketamine, magnesium sulfate, or even lignocaine. So this usage of non-opioid drugs is called opioid-sparing analgesia. Okay, so that should be the first choice for obese patients because you don't want any respiratory dispersion, especially if they have history of OSA. This should be the ideal way. Then how to manage ventilation in the post-op period in obese patients? Is there any specific advice that is required?
The head and elevation can be made mandatory.
Yeah,
And
that is
spiral.
mandatory for every patient. But ventilatory strategies, supposing patient is
CPAP.
morbidly obese patient with OSA or apnea OSA syndrome, may require mechanical ventilation. Better to mechanically ventilate them for a few hours, then extubate. Less severe cases can be managed with CPAP or supplemental oxygen. Hypoxemia may occur up to 3 days after surgery. So you have to be very, very watchful in these patients. How to prevent DVT?
Floatron cuffs can be used during ICU stay.
So it should start from the intraoperative period itself. You should use the dead stockings or the compression methods during intraoperative procedure, and start either heparin or low molecular weight heparin should adequately earlier, and then start resume those doses 6 hours after surgery when the bleeding risk is less, and then early ambulation and mobilization. Okay, DVT prophylaxis, early ambulation is mandatory. Then how to manage nutrition and why management of nutrition is important. Wherever indicated, early enteral feeding. This is a rule for everybody. Okay, it's not only for obese patients, but every patient, if oral feeds can be tolerated and indicated, then early enteral feeding is a must for every post-op patient, including obese patients, preventing 14 calorie malnutrition. And also, if this is not done, the chances of wound infection and poor wound healing can happen in these patients. Okay. So this slide is important just for you to remember what are all the points that you have to take care when you manage a obese patient, especially morbidly obese patient. The mnemonic is a prime minister at public function. All of you know there was a public function with the prime minister recently. Of course, nothing politically engineered. So APMAPPF. So A stands for airway. That is the first and foremost concern. Detailed evaluation and planning essential, including awake fiber optic intubation. Then position. You must always have a head-up position unless otherwise some other position is needed for surgery. Always head up during induction and recovery, or ramp and L position for better view during laryngoscopy. Monitors, NIBP cup size, EKG tracing for IABP, SpO2, EPCO2 and temperature monitoring. The agents of choice, the drug dosing, volatile anesthetic selection, and neuromuscular blocking drug usage, all that's to be planned in advance. And what technique you are going to use, like what are you going to do for difficult IV access, whether you have to have a central line wherever regional is possible, are you going to use that, or when there is a GA, what are the precautions that you have to take. And pain relief, careful use of narcotics intraoperatively, especially if the patient has OSA, and multimodal analgesia in the post-op period, and fluids replacement on lean body weight basis, avoid rapid filling. So if you remember these 7 points, I think you can fairly manage all your even morbid obese patients in a reasonably well good way. So that concludes the discussion on. So it is mostly for planned for quick answer writing in theory, as well as important points that you have to remember for your practical exams if you get a obese patient coming for surgery. So it is not a detailed CME level discussion on obesity. So I think you just pass your opinion or your doubts or your corrections, whatever you want to say, you are free to do that now. Any questions or any points you want to add or you feel have been omitted? Sanjuta, have any questions?
No, sir.
Where
No,
is
sir.
Vidya? Vidya is not in duty today. Vidya,
Yes,
I would
sir.
like
Yes, sir.
guest. Who is the guest? Guest doesn't want to reveal their name. Okay. Right. Kamachi,
Yes, sir.
and we say, I think nobody is willing to ask any questions. Do you have any questions?
Actually, as Vasanthi madam suggested me that
Hmm.
before coming to the class, the previous day, I should give them some questions, sir.
Yeah. I thought,
So
by the way, you are the
they
one
should
questions
prepare answers,
Hmm.
and at least they will be prepared with some answers to respond when you ask questions, sir. From next
Very
class onwards, COPD,
Hmm.
we will circulate the questions on Tuesday or Wednesday itself.
Okay.
Some
okay.
interesting questions that will be useful for them in exams.
That's right. Okay, we will do that. Okay.
Yes, sir.
Right.